Today we're going to be talking about physician-assisted suicide and what its role is in terms of end-of-life care, and specifically highlighting some laws regarding California. So starting with physician-assisted suicide, we want to define it. It gets a bad rap with its name, especially in the suicide part. However, physician-assisted suicide can be defined as a physician who is assisting a terminally ill patient in ending their life with the request of their own volition, and he prescribes medications to that end. So the physician is actually not administering the life-ending drugs. He prescribes them and the patient takes them on their own, which leads us to some common misconceptions, which are that it replaces palliative care or that it's a withdrawal of care. None of those are true. Palliative care focuses on end of life and comfort, where through pain management, which is a little bit different than physician-assisted suicide, or PAS, which focuses on allowing the patient to make their own decisions in regard to death and facing their illness. And euthanasia differs a little bit in that the physician is actually administering the medication to terminally end one's life. And withdrawal of care is complete withdrawal, stopping treatment, and that's just not the case with patients who seek out PAS. They still receive care as if nothing were changed. So we're going to look at a little bit of the history of PAS. In California, it was officially passed on October 15th, and 90 days thereafter it was enacted into legislation, so becoming an actual law where patients could seek it out. But it's been around for quite a while. In Oregon, it's been enacted since 1997, in Washington State since 2008, Vermont since 2013, and worldwide in the Netherlands since 2001, Belgium in 2002, and Luxembourg as well in 2009. Interestingly, Switzerland has had some laws regarding PAS since around the 1940s. So, delving into a little bit of the regulation in regards to California, in order for a patient to seek out physician-assisted suicide, a few things have to be in place. One, they have to have a terminal diagnosis, meaning that their prognosis is that they will die within probably 6 months. And they have to submit a formal petition, 2 formal petitions, each 15 days apart. They obviously have to be an adult, 18 years or older, to make that decision, and their petitions have to be signed by 2 witnesses, and the medications must be self-administered. And the patient also has to be of sound mind and body. They can't have any type of mental breakdown, and if the physician suspects this, they can request for another evaluation from another physician, whether or not they want to pursue down the road of PAS. So why would you use it? Some common uses that patients cite would be from fear of pain from their diagnosis or actual pain, unbearable suffering. When you reach the end of your life and you're just finding no relief, then you may feel like you have no other options. Some other issues might be a loss of autonomy, or feeling like you no longer in control. You feel like you're losing your dignity, and you're losing your independence. All of those things can play a role into why someone would seek out PAS. So what are the type of patients that use it? Again, we kind of just covered some of the symptoms of why they would seek it out. But as far as patients go, about 50% are usually patients who have cancer. In the other population can vary, but really any type of terminal illness that can be, it can include pulmonary diseases, neurological disorders, which can begin to be a little tricky as your neurological function may begin to deteriorate, and then the patient may not be considered of sound mind to be making that decision. So again, just any type of terminal illness would qualify a patient, again, if they have a less than 6-month prognosis to live. So starting the conversation can be something that's extremely awkward. It's an uncomfortable position to be in, both from patient physician standpoint, talking about death and dying is not something that's easily done. However, it's important to remember that keeping an open dialogue and keeping trust and a good back and forth between the physician and the patient can result in a very rewarding and an empowering circumstance that creates the best outcome for the patient, which is the ultimate goal, really. And then one of the other benefits is it can open up some doorways that the patient may not have wanted to talk about before, such as their fear of dying or fear of the pain or fear of what's to come in regards of their illness. And the physician can open and begin to talk about these issues, and then kind of really highlight, zero in on maybe there's some other alternative options, and they don't have to pursue PAS. So real quickly looking at some of the patient's rights, now that it's enacted in California, California residents do have the right to pursue physician-assisted suicide, which means that they really just have the ability to die with dignity if that's what they so choose. And it really just comes down to empowering them to make choices and giving them options, especially when they feel like there's no other options in regard to their outcomes. But one of the most important things to remember is that they do have the right to back out. Just because you started that conversation or started the process does not mean you have to go through with it. Even up until having drugs prescribed to you, you still don't have to go through with it as a patient. And then some rights of the physicians is they don't have to participate in PAS. They can refuse treatment if they so choose, which is important to remember. But I would suggest that if that's the choice the physicians make, that they help the patient find a physician who's willing to work with them. So real quick, we're going to look at a couple examples of real-life uses of PAS and some really great examples, in my opinion, of how it can work. There was a 40-year-old female who was diagnosed with ovarian cancer, and she really followed all of the typical guidelines as far as palliative care and pain management and everything that you really look at in terms of a terminal illness. And ultimately she also decided to pursue PAS, prescribed medications, and she saw it as her backup plan, as a way out. In the end, she actually didn't go through with it. She didn't use the medications, and she was able to die peacefully at home through proper management of palliative care. Conversely, there was another 80-year-old man who was diagnosed with pulmonary fibrosis, who prior to his diagnosis was very active, but as his disease progressed, he became increasingly sick, short of breath, a lot of pain, and decided to pursue PAS himself. And he was at peace in his mind. He decided that's what he wanted to do. He went through with it, and he, like the woman, died at home with his family in peace. So I think these two examples highlight what really PAS is all about, and giving options to patients. So some ethical considerations. A lot of people cite the slippery slope of opening up an idea like this and what it will cause. Just a cascade of everybody, physicians having to participate in this assisted suicide, which is really not the case. There's some good documentation or some good regulation around the law that prevent that from happening, and as long as those remain intact, I don't see that as an issue. And as practicing medical professionals, we really want to respect the autonomy of patients, which includes following their wishes. And if patients feel that this is their ultimate goal and they feel like there's no other options, then it's important to respect their wishes as far as regards for them pursuing PAS. So some takeaway points is that California residents do now have the right to physician-assisted suicide. And really what that means is that they just have options to go through. And physicians can say no, and again, I would stress that if they do say no, that they should help the patients find other means or other physicians willing to work with them. And it's a difficult conversation to have, just like palliative care. In regards to death and dying, it's very uncomfortable, but it can be important and rewarding conversation as well to help that person onto that next phase of their life or ending their life. And again, the most important part is patients do not have to go through with it. That's not something that they need to follow through with. You have the option to say, I changed my mind.